Hi, this is Dr. Mo Mortazavi. I am going to be presenting our slides looking at the findings and clinical utility of brain MRI and concussions with persistent post-concussive symptoms. And, okay, so our goals here were to look at the PPCS, or the persistent post-concussive symptoms group, which in the literature is anywhere between 10 to 30% of the patients with concussions. And these folks have a variety of symptoms, including migraine, vestibular, visual, cognitive, mood, and others. And by definition, we have this group at longer than 1 month of symptoms. MRI studies have been performed in this group to rule out underlying pathology and potentially help us with their recoveries, but we don't really have any direct guidelines because of lack of literature in terms of indicating the optimal time for pulling the trigger on the MRI and what is the value and clinical utility of the findings when there are any findings. For practitioners, it's really unclear how often these MRI studies actually give us valuable information, change intervention, and how frequently we should be obtaining them in this population with prolonged symptoms greater than a month, which is 10 to 30% of all concussions. That's not a small number of patients, and certainly a majority or a big part of my patient panel are patients with prolonged symptoms. So looking at these MRI findings was very important to us. So this was a retrospective pilot study. We looked at a cohort of patients, again, with persistent post-concussive symptoms defined by symptoms greater than 4 weeks or 1 month. This group had neuroimaging performed given their ongoing symptoms. Patients with any history of seizures, other neurologic disorders, cancer, pregnancy, and any bleeds that were identified acutely on presentation, whether it was CT or MRI, were excluded from the study. Only folks that had delayed neuroimaging or early negative CT were included in the study. So the MRI was done utilizing a trauma protocol with a 3T magnet to optimize sensitivity for microhemorrhages and white matter changes. And the results were essentially broken down into what we classified as incidental findings that had nothing to do with the trauma, such as sinus abnormalities, cysts, polyps, vascular anomalies, etc. And likely trauma-related findings, which would have been bleeds, microhemorrhages, white matter changes, and in our study, white matter changes were the main ones that we saw. So here's the results. We had 42 subjects with persistent post-concussive symptoms and MRIs, and we saw that basically majority of these MRIs were negative. So you can see 57%. So not the 90% majority, but still about 60% were completely negative, and about 40% did show some findings in this cohort, although the majority of those were incidental findings, which I'll show you shortly. The other interesting data point here is when these MRIs were obtained, and they were obtained on average at 3 months or so after the date of injury, with most completed somewhere between 2 and 4 months. So let's look at the actual 40% that had positive findings, quote unquote. So most of those, and you can see about 60% of those, were considered incidental, non-trauma related findings, like the ones I pointed out earlier, and 8 of the 19 that were positive, so not an insignificant number, were white matter changes and considered to be trauma related. The average time of MRI completion in the group with positive post-traumatic findings, the positive white matter changes, was more or less 3.5 months, so not very different than the entire group. So we tried to break down those that had the post-traumatic abnormalities, so the white matter changes, to see if there was any subgrouping classification. And here's what we saw. We saw bimodal distribution with respect to age, and 5 out of 8 of them were females that had the white matter changes. We also wanted to look at in what stage these abnormalities were most common. And what we found is they were most common in the PPCS stage 3, which was anywhere between 6 to 12 months of symptoms. The most common primary symptom profile was the migraine headache profile, as you can see down on the table below, and vision as well. Those that had visual subtype post-concussive syndrome or persistent post-concussive symptoms. We also looked at the cause and found that motor vehicle accident was the most common mechanism of those with abnormal MRIs, but is the least common in the group that actually had white matter changes. So there really wasn't any relationships there with mechanism that were significant. And maybe the most important point is there was no additional interventions necessary based on any of the MRI findings. So none of the incidental findings required direct intervention, and none of the assumed post-traumatic white matter changes received any direct intervention, although they were obviously considered as part of the management and part of the complexity of the case. So what were some of the limitations that we had? Unclear whether these MRIs were present prior. These MRI findings were present prior versus caused by the head. We still don't know. It's certainly possible some of these white matter changes were there to begin with. So that's certainly a limitation. This was a small pilot study, and that's something we want to build on with the number of patients that we have with complex cases and the number of MRIs that we continue to get. So increasing the sample size will help us quite a bit. And we're unable to determine any kind of correlation with severity of white matter changes to the persisting symptoms. And may need to consider serial MRIs at some point from an investigational perspective to track some of the neuroanatomy changes that are occurring. So the significance of our findings, I think the big points to hit home here are that, and I basically talk to patients about this when they ask about MRIs. And what I say is, well, majority MRIs are negative. And we did have findings, in about 40%, but majority of those were incidental. And of those that did have findings, so in our sample was 8 out of 42 that were, positive post-traumatic changes, which is, still a significant, close to a 20%. And, for those guys, it may have to some degree, come into play with our management indirectly in terms of being more likely to get them formal rehab services and that sort of thing. But there was no direct intervention for those white matter changes. We did do some subgroup classifications and found that these abnormalities were more common in females and those with symptoms of greater than 6 months in particular. So, with the limited research that's out there right now on MRI findings and the clinical utility of MRI in this unique, complex population of PPCS. Our data is suggesting that MRI findings are, obviously more commonly negative, but certainly there are some findings that may be valuable to see, such as white matter changes. But when we pull the trigger, maybe should not routinely be at 1 month when they are identified as prolonged or persistent post-concussive symptoms, because we know that even those with prolonged symptoms, the majority are better by 3 months. So that sort of 3 to 6 month time frame could be, just like we saw in this study, a sort of a better time frame, obviously assuming there's no red flags where you need the neuroimaging earlier, to sort of say, okay, the symptoms have been going on long enough. Once we get to about 3 months, we probably need to be looking at the MRI. And it also, I think, not only buys time for a large portion of those that you would have scanned to hopefully just get better and avoid the MRI. But if you get to the point where you're going to do the MRI, you can focus on doing a little bit more sophisticated MRI using the 3T, maybe considering including a DTI as well. With where we're at today, those are relatively easy things to do, and the minimal increase in cost is, in my opinion, um, certainly outweighed by the clinical utility of having a more sensitive MRI, and also getting somewhat of a functional glimpse with the DTI of the white matter. So these are some of the future directions that we're looking to go into. And we certainly, as part of our 3T MRIs, are obtaining DTIs as well, and hoping to be able to publish some data on that, and expand our study to subclassify into concussion subtypes, and how those injuries can affect MRI, or how MRI findings can shed light into those. So thank you for your time, and be safe. Thanks.